further ado, I'm going to pass you over to Adrian Boswood. He's going to give you a lecture. Adrian, over to you.
Thank you. And first of all, welcome to everyone who's joining this presentation. It's a great pleasure to speak to you all. And it was lovely a moment ago to see all of your smiling faces and waving hands. That's fantastic. I noted in the chat that one of the people, Heather, said that she's in Scotland at the moment and it's raining. I was actually on holiday in Scotland last week, and similarly last Friday the temperatures were 30 degrees in the south and we were out in rain on one of the Hebridean Islands, which was beautiful nonetheless. So it may not be hot, but it's still a great place to be. I have the pleasure this afternoon of talking to you about a couple of areas of my interest, actually. Just a little bit of background about me. As you can see from the sort of title that I put on my slide, my area of specialty in the veterinary field is veterinary cardiology. So I work with dogs and cats who have significant cardiac disease. But I'm also very interested in sort of research and study design from the point of view of actually how do we conduct research that can help to establish whether or not medicines that we use frequently in veterinary medicine are effective, and what sorts of standards should we apply before we accept a medication as being something that we're going to use. And I'm just going to kind of talk you through that a little bit today. And I think it's really quite helpful to pick up, first of all, with a sort of a couple of current examples. So the first one, and this might be someone, the sort of thing that someone would say to you in conversation, and I'd like you to just sort of think about this for a moment. So hold on, let me get my slide to advance. So if I was to say to you, every time I have a cold, I have taken high-dose vitamin C, and I am absolutely convinced, because every time I've had a cold, I've got better. And so I would conclude from that taking high-dose vitamin C must make you recover from the common cold. Now, what I want you to do is, you can see there's a little website address, and you can access this on your phone or just have it as an additional browser window on your computer. But if you go to that www.menti.com, and I will go to that now, what I'd like to do is ask you a question about that, which is on the basis of those three statements, which is every time I have a cold, I take vitamin C. Every time I have a cold, I get better. Therefore, vitamin C must help you get better from a cold. What do you think about that conclusion? So there's really three options I'm going to give you here. That it's correct. That's a good logical conclusion that a vitamin C is effective. That it's incorrect. Let me just hide the results for a moment, although I can see how many of you have voted. It's incorrect because I would have recovered from a cold anyway, or maybe it's just a little bit confusing that you're not quite sure what to conclude from that series of statements. So can you conclude that it's right? Can you conclude that it's wrong? Or can you just conclude that you can't conclude anything? And I'll leave that question slide up for a little bit longer. I know there were 60 odd participants in the presentation, and so far we've got about 37 of you who'd voted. By the way, also, while I say this, while I'm giving you the opportunity to vote on this slide, if you have anything that you would like to pose as a question, then feel free to pose that in sort of a Q&A or chat while we're going along. And what I'll try to do is answer that either while I'm going along, or alternatively, in the sort of wrap-up questions at the end. So let's see, for those 44 of you now who have responded, let's see what the answers are. Okay, so if we take those answers in sort of series, what we can see is that although two people thought that my statement was potentially correct, that there might be a cause and effect, I would tend to agree with the 39 people who've said, well, I probably would have recovered from the cold anyway. In fact, that's really one of the characteristics of the common cold, is that pretty much whatever you do, you get better from it. And so we can't conclude, just because of the fact that typically every time I take vitamin C, that vitamin C is what it is that causes us to recover from the cold. I'm not sure that you could necessarily go so far as to say that that statement is incorrect. It's still a possibility that vitamin C might be contributing to my recovery, but I think it is wrong to make a bold assumption that it's the vitamin C that's bringing that effect about. And for the 6 of you who were confused, then that's a very honest statement for you to make. And it is a confusing area for sure. Now, what we're going to do is I'm going to come back with another question a little bit later, but if I just kind of go back to my slides, I hope that what that really has illustrated to you is the difficulty on an individual basis of making any inferences about the effectiveness of a treatment when you're treating a disease that has a sort of a natural course or a progression that it might have taken anyway, irrespective of whether or not you've taken that drug. Now, this is a very topical thing at the moment, and I use an example of Donald Trump. And the Donald Trump, let's not get too political here, but there has been some criticism of his approach to and management of the coronavirus outbreak in the US. But one of the things that he did was early on, relatively early on in the course of the outbreak, he announced that he was taking this drug, hydroxychloroquine, and he said that there was good evidence to suggest that it was effective, and that it was particularly effective in what they called post-exposure prophylaxis. So if you thought that there was a risk that you had been exposed to someone who had coronavirus, then there was a possibility that had been raised by some people that taking hydroxychloroquine would reduce your likelihood of subsequently going on to develop the clinical signs associated with COVID-19. And at the time that he made that statement, there was a lot of controversy, there was a lot of argument to and fro. And we can think also of that in terms of whether or not we can formulate a specific question, which is a question that we can test by doing an appropriate trial, that can then give us a clearer idea about whether or not medication genuinely works. Just going to scan through. Here we are, other password for Menti, that's great. Yeah. Yeah, definitely there's some bad science going on there. I'm glad that some of you have talked about Bad Science by Ben Goldacre. That's definitely a publication worth reading. And yeah, indeed, causation rather than correlation, that's a very good thing. Yes, there was some discussion about whether or not to take bleach. I'm not going to design a study. The last comment that was there on the chat was, you're not sure about the current conclusion, and this is, well, wait for it. We may find out something more later in my presentation. So really, we are considering, what does it take to prove that a medication is effective? And establishing the effectiveness of medication, we can sort of pose a generic question. And let's say the question is, will treatment X improve the outcome of patients with condition Y, whatever that is? And so what we could say in the case of my vitamin C was, will vitamin C improve the outcome? And in that case, that would be perhaps speeding the recovery or leading to the recovery of patients with the common cold. And in the case of Donald Trump and others, the question would be, well, will hydroxychloroquine improve the outcome of patients with exposure to SARS-CoV-2? So SARS-CoV-2 is the coronavirus that causes COVID-19. And what was hoped with hydroxychloroquine was that if you'd been exposed to SARS-CoV-2, you had a lower risk of contracting the infection and developing clinical signs of the disease if you took the hydroxychloroquine. And what you can see is that there's a very generic question here. All we have to do is say, well, what's treatment X that we're interested in, and what's condition Y that we're interested in treating? And we can then sort of come up with some kind of study that will help us do that. Now, the standard study design that helps us to answer treatment-related questions is a study design doing what we would call a clinical trial. And clinical trials actually are very simple in terms of their experimental design, although how you conduct them might be quite complicated. The basic idea underlying most of them is quite similar. And I'll just kind of talk you through that on this animation at the moment. So if we consider that we have a group of patients with condition Y, whatever that might be, and in the case of what I talked about originally, the condition Y would be the common cold, if I was interested to know whether or not vitamin C affected the outcome of the common cold. Condition Y in the case of COVID-19 and exposure to someone with the virus would be that you have had a exposure to the virus but not yet contracted the disease. So that would be a patient with that condition. Now, typically what we want is for the people recruited to our clinical trial, or the subjects recruited to our clinical trial, to have particular characteristics. So we might not want absolutely everyone who's been exposed to someone with coronavirus to be in our clinical trial. We might only want a more limited study population. And one obvious reason why someone who was in the first population, patients with condition Y, might not get into the study population would be if they'd actually already developed the disease, because we're trying to prevent its development. If you've already developed it, then you wouldn't be suitable to be entered into a clinical trial. So a population typically is screened for entry to a clinical trial, and they meet some criteria to get into that trial. And then after that population has met the entry criteria, they're usually randomized into two groups. And randomization is very important. I'll come back to why it is in a moment. But they're randomized into a group who does receive the drug that we're interested in, so a group receiving drug X. And they're randomized also into a group that do not receive drug X, our control group. And those groups are compared over time for the development of whatever endpoint it is that we're interested in. So those two groups, we hope, are balanced for confounding factors. Now, what do I mean by confounding factors? As we all hear regularly in the news, for instance, about COVID-19, there are some people who are particularly susceptible to the disease and particularly susceptible to getting a worse form of the disease. So if you only gave your drug to people who were less likely to get the disease in the first place, it might look like it worked, but it was just an effect that actually you were treating two slightly different groups of patients. And the reason that the way that we try to get these two groups of patients as similar as possible is by randomly allocating people to one drug or the other. And the point of random allocation is therefore that what we should be doing is eliminating any potential bias in the administration of the drug, and therefore revealing the true effect of the medication, rather than necessarily revealing actually that patients were unequally allocated to the two groups. And we follow those patients over a period of time until they reach an endpoint, and whatever that endpoint of interest might be. So if I was doing a study on vitamin C, the endpoint would be recovery from the common cold. If I was doing a study with hydroxychloroquine, then the endpoint might be either getting or not getting in a finite period of time the COVID-19 symptoms. So we can see, we can design a clinical trial according to what drug it is we're wanting to test and in what sort of population. So there's this generic structure of a clinical trial, which is we have a group of patients or a group of subjects. Some of them we administer a particular intervention that we're interested in, drug X. Some of them we administer a comparative intervention, We're interested in how frequently or at what rate they develop a particular outcome, say recovery from the common cold, and we would usually monitor them over a period of time. Ethically, in a clinical trial, you have to ask yourself, if you were enrolled in a clinical trial, you would like someone to have carefully considered the ethics of it beforehand. And the same is the case in veterinary medicine, in that we should only conduct a study, particularly if we're doing a study in client-owned animals, so in patients who present to our hospitals, whereby we can ensure that an animal, or ensure to the best of our ability, that an animal going into a clinical trial is not in some way harmed. And so we shouldn't do a clinical trial to test the effectiveness of a drug if we already know the drug works, because as I've said, we should have a control group in the study, and the control group have a medication systematically withheld. So we shouldn't systematically withhold a drug that works. But similarly, if the drug is already known not to work, but may have some side effects associated with it, we also should not conduct a clinical trial, because we would unnecessarily be exposing individuals to the drug. So we would do a trial where we thought that the drug might work, in fact, where we were reasonably optimistic that it might have an effect, but where we don't know for sure that there is an effect. And that's what's called optimistic uncertainty. So, I'm just scanning some of the chat for the moment. Yeah, don't drink bleach. That's the main thing. There's a question there: can human clinical trial results be used in application to different species? That's a really great question. There's no substitute for doing the study in the species of interest, but there are a lot of drugs that we give to animals that have similar effects in humans and are similarly effective for the same diseases. So they can't necessarily be applied at the same level of confidence, but they can be applied. So carrying on in terms of our clinical trials, we need to think carefully about what sort of patients we want in the study, and that's defined by inclusion and exclusion criteria. So patients who sort of fit the bill, as it were. And we need to decide carefully also on what the comparative treatment is going to be that we're going to put individuals on. And what we, I love that, isn't that the reverse card for testing testing human drugs on animals? To some extent it is actually, and it's a really good thing. So what is the most valid comparison? And some studies are what's called positive controlled, where the control group receive a drug that is an effective drug, and we're looking at, is the new drug more effective? And some studies are placebo controlled, and a drug trial is most ethical to include a placebo where there isn't a known effective treatment for the disease that you're treating. And so the most ethically acceptable treatment would be the most effective currently known therapy. So moving through then, the question is, how is this relevant to veterinary medicine? And in veterinary medicine, we need a high level of proof of effectiveness of our medications in the same way that we do in human medicine. And in fact, to the extent that in recent years, an obligation by our regulatory body, what's called the Royal College of Veterinary Surgeons, is that veterinary professionals should practice what's called evidence-based veterinary medicine. So we need to consider the evidence of the effectiveness of treatment before we administer that treatment, and we should be administering the most effective treatment known, providing there's not a reason that it shouldn't be given to a particular patient. And the best evidence is obtained from well-designed clinical trials. Now, if we take an example from veterinary cardiology, the area in which I work, cardiac disease is very common in dogs and cats. They actually get somewhat different diseases to what humans do, but as you'll hear regularly, cardiovascular disease is also a common condition that affects humans. And in some of the conditions that dogs and cats get, they can eventually go on, their disease can progress, they develop clinical signs of illness, and unfortunately, many dogs who have significant cardiac disease die of that disease ultimately. The most common disease that small animal cardiologists deal with, so in dogs and cats, is a condition called degenerative mitral valve disease. And it would be great to know whether or not the treatment that we administer to those patients is effective. What I then set out to do, I was fortunate enough, was to conduct a clinical trial in mitral valve disease. And I'm just going to explain a little bit more about the background of that. So degenerative mitral valve disease is a condition that arises where, for reasons that we really don't understand very well, the valve that should prevent the backflow of blood from the left ventricle to the left atrium in the heart, for some reason degenerates with time, and in patients beyond a certain period of their life, so typically middle-aged to older dogs, get a leak in that valve that imposes an additional burden on the heart for reasons that I will explain. So if you look at this diagram that's at the bottom right here, the arrow here is indicating where the mitral valve is, and normally flow through the mitral valve should be from the left atrium into the left ventricle, and then blood is ejected out of the aorta when the heart contracts. The problem becomes when this valve here leaks. And so if we look at this next diagram, we can see we have the left ventricle here and the left atrium above it. And when this valve leaks, each time the heart contracts, not only is blood ejected out of the aorta as normal, but some of it's ejected back into the left atrium. And the way that the heart initially tries to cope with this is, as the leak gets worse, and therefore as more blood has to be pumped, the heart begins to get bigger. And first of all, it goes through a phase where it's bigger and the animal can cope. But ultimately, in some dogs, certainly not all, it goes through a phase where the heart ultimately gets so big that the animal goes on to develop signs of heart failure. Now, we can see this disease. This is a gross pathological picture of a very distorted abnormal mitral valve in a dog that's undergoing post-mortem examination. And the colourful pictures on the right are pictures under a microscope of these lesions, what's called myxomatous change in the valve. But we want to be able to detect this in living patients. And there are various things that we can do in order to do that. So just to explain a little bit more about the progression of the disease, this disease actually takes years to progress in most dogs who have it. And in the earliest stage of the disease, and actually the stage of the disease that is the longest, these dogs have a little leak in their valve. They have absolutely no clinical signs associated with it, and they do fine. Now, some of those dogs progress to the stage where they're in what we call stage B2, where they still have no outward clinical signs, but their heart is big. And we recognize that enlargement of their heart as being a sign that they're sort of on the pathway ultimately to developing signs of congestive heart failure and developing a problem associated with their disease. And when they go into congestive heart failure, they're in stage C. And what we were very interested to know was, is there any medication that we can effectively administer in stage B2 of the disease that will delay the progression of animals into stage C of the disease? And if you look at a population of dogs with this condition, it's sort of a pyramid size because of the relative duration of the different stages of the disease. Most of the dogs in any given population with this condition will be in the earliest stage of the disease where their heart's a normal size. So they say we don't have cardiomegaly, their heart isn't big, and they have no clinical signs. As the disease progresses, there'll be quite a few dogs that will have an enlarged heart and no signs. Fewer dogs actually in heart failure, and then there are some dogs right at the end of their disease who have what's called refractory heart failure. And that's reflected in, you look at sort of population size. If you look at this pie chart here and focus on the relative size of the B1s, B2s and Cs, more than half of all the dogs affected by mitral valve disease, because let's ignore this little segment here, more than half of the dogs who are genuinely affected are in stage B1. Then about a quarter, just over a quarter, are in stage B2, and then less than that are in stage C. So how can we find these patients? Well, actually, they're very easy to find because all dogs who have a leaking mitral valve, or at least if their mitral valve is leaking substantially, will have what's called a heart murmur. so that when you listen to their heart with a stethoscope, you'll hear an additional sound. And kind of the classic sounds that you expect to hear when you listen to a heart are lubbed up, lubbed up, lubbed up. The first and second heart sound, the lub is the first one, dup is the second one. And those two sounds are the normal things that you hear when you listen to a dog and a cat. But if you have a leak in a valve and that leak happens when the heart is contracting, then instead of lubbed up, you get lubwushed up, lubwushed up, lubwushed up. And the whoosh gets louder as the disease progresses. And what we can do is perform a number of diagnostic tests. Question is, would you hear a murmur in stage B1? And the answer is yes, you would do. There's enough leak in stage B1 for there to be a quite audible murmur, but it tends to be a quieter murmur. We would then undertake diagnostic tests to both establish that the disease is definitely present and to characterize the severity of that disease. So let me just progress that. The diagnostic test that we most frequently undertake in animals is what's called echocardiography. And echocardiography is the same as a cardiac ultrasound examination. And what, as I said, that helps us to establish that the disease is definitely present. And most importantly, at least for the identification of dogs at stage B2, where their heart's beginning to enlarge, is we can take measurements of the two main chambers on the left side of the heart, left atrium and left ventricle, and see, do those measurements exceed values that we would expect? And if they do, we'd say the heart's big, this is a dog that's probably in stage B2 of their disease. And the physics of cardiac ultrasound is actually surprisingly straightforward. Sorry, question in the chat, certain breeds more prone to it? Most definitely, and the sort of poster child for mitral valve disease is the Cavalier King Charles Spaniel. They get lots of valvular heart disease. Of course, the question then is why, and we suspect that there's a genetic predisposition, but that's not been proven. If you look at this diagram to sort of illustrate, we have a cardiac ultrasound transducer, which is this thing that's at the top here. And imagine what that does is it emits little packets of cardiac ultrasound. And those little packets go off, they hit a structure in the heart and they bounce back. And so in essence, what they do is you send out ultrasound from the ultrasound transducer, it reflects back to the ultrasound transducer, and if the computer attached to the ultrasound transducer knows how fast ultrasound travels, it can create an image of the heart on the basis of the returning echoes, which is why it's called echocardiography. And this is a picture of a dog. This is actually me, and this is a dog undergoing cardiac ultrasound. Here we have an ultrasound machine, and I'm holding the ultrasound transducer actually beneath the table, just under the dog, gently pushing up onto the dog's chest in order to obtain the ultrasound image that I'm interested in. And this is a video loop. I hope you can see the video loop playing of a dog's heart as it undergoes an ultrasound scan. And this is a sort of a typical appearance of one of the views. Oh, let me just see. Physics flashbacks. Yeah. Genetic. Yeah. Could it be bred out of the breeds? That's such a controversial question. It's a great question, but it's so endemic in certain breeds that it would be very difficult to see how it could happen. So looking at this chamber here is the left atrium. This chamber here is the left ventricle. I hope you can see my cursor illustrating that. And in between the two is the mitral valve. And we can superimpose an additional technique called color Doppler echocardiography, where if we see this little flash of color in the left atrium each time the heart contracts, then that confirms that the mitral valve is leaking. And then if we look at the video from the next dog, not only is the valve leaking, but first of all, the magnitude of the leak looks worse because there's loads more color. And secondly, that dog's heart is bigger. So this is a dog with more advanced disease. It has a big leak in its mitral valve and enlargement of its left atrium and its left ventricle. So this is a dog with more advanced disease. Now, we started out then with a question that will the administration of treatment delay disease progression, and particularly will it delay dogs going into congestive heart failure? And the treatment that we wanted to evaluate was a drug called pimobendan, because that was known to be effective in later stages of the disease, and there was rationale to believe that it might be effective in stage B2. So we First of all, we want to state our hypothesis. So in a way, the question, does the administration, it leads to a hypothesis. And if we state that in a clear enough way, then it can help us to design an appropriate study. So our hypothesis, we hypothesized that the oral administration of pimobendan chronically, so over a long period of time, to dogs with increased heart size secondary to mitral valve disease, not receiving any other medication, would delay the onset of signs of congestive heart failure or cardiac-related death or euthanasia in comparison to dogs not receiving pimobendan. And that's a study that we set out to undertake. And I'll just briefly explain to you what we found when we did that. There is a valve in the dog's heart that's called the tricuspid valve, and actually it has an awful lot of sort of leaflets. It's an anatomically quite complicated thing. But it is meant to be down to the fact of whether they have a bicuspid or a tricuspid valve, because that counts the number of leaflets. But it's a little bit oversimple to say that one has 2 and one has 3. Okay, so moving on. So that was our study question. Dogs with the evidence of preclinical disease with enlargement of their heart was our study population, and signs of congestive heart failure or cardiac-related death was our endpoint. So we did a study, and this was the article that we finally published as a consequence of doing it. This was published back in 2016. What you can see is there's loads of authors on this study. I was fortunate enough to be leading the clinical trial, but we had about 36 different investigators from centres all over the world participating in it, so that we could enroll enough dogs to be confident that we would show an effect, if indeed an effect was present. And the study itself took us about 5 years to do, so it takes a very long time to do something like this well. And if we go back to the generic study design that I showed earlier, so we have dogs with mitral valve disease and we screen them to see whether or not their hearts are big, and that becomes our study population. And then we randomize them into a group that does receive pimobendan and a group that doesn't. And then we follow them up over a period of time. So our patients in the study are our study population. Our intervention group are receiving pimobendan. The comparative intervention, in this case, we chose placebo because there wasn't an established effective medication in this disease, and the outcome of interest was our primary endpoint. Now, here's a question for you. And again, let me just hold on. I need to go back to sharing my screen and go to that and progress it. So oh, that's good. We've got some love hearts. So here's a question for you. If you have studied statistics at school, how much do you enjoy it? And the answers to this are completely anonymized. And so this is not actually some sort of hidden test of how numerate you are, but it's actually something I'm just genuinely interested in. So there's no, you can be as honest as you like, and there's no reason to provide sort of a deceptive answer. So we're into the 30s now. Oh, and there's something in the chat which I'll look at while people are voting. Yeah, so yeah, it's the worst thing I've done at school, except history, maybe. Yeah, okay, that's very funny. And okay, sorry to hear that that's been your experience of it, but there we are. Okay, so some people who say a lot. This is actually something that polarizes people quite a lot as to whether or not they like statistics, and there are always some people down here who hate it. One of the things I found challenging, shall we say, about statistics was that when you're taught it in a very dry way, which doesn't necessarily show you what it can actually do and where its value is. And it's causing very lively chat. And so when I started to care about statistics, and some people would argue when I became a bit of a nerd, was when it started to answer questions that I genuinely wanted to know the answer to. And the way that we can decide whether or not treatment works is to perform a statistical test on the basis of the results that we observe and compare the two groups. And so what we want to do is to compare the groups either in terms of how many of them develop the endpoint we're interested in a finite period of time, or alternatively, whether the proportions of dogs in the two groups who develop those endpoints differ over the duration of the study. And the question that statistics should be asking is, how likely is the observed distribution of the outcome if the drug doesn't work? And that's what's called your null hypothesis. Your null hypothesis is that the drug doesn't work. And that then is expressed on the basis of a probability, or what's called a p-value. And I think I probably like statistics as much as most of you until I started to realize the questions that it could help me answer. Usually we say that we'll take that a result as significant if the probability of the outcome being true in light of the null hypothesis is less than 5%. And effectively what we do is we get rid of the null hypothesis. So this slide, let me just have a little look at the chat. It's fine. This slide here is on one picture summarizing the outcome of a study that took more than 5 years. So it's worth spending a little bit of time going through it. What we have on the horizontal axis is days, and on the vertical axis, we have the percentage of dogs who have not yet met the endpoint that we're interested in. And we've got two lines, which are different colors. And the blue line represents the proportion of dogs in the placebo group who haven't met the primary endpoint yet. And the green line represents the proportion of dogs in the pimobendan group. Now, because the endpoint here in this study is a bad thing, which is either going into heart failure or dying, then the group of animals in the higher of the two lines, fewer of them have yet at any given point in time gone into heart failure or died, and therefore they're doing better than the other group. And what we can see is that pretty much throughout the duration of the study, the pimobendan group are doing better, or the placebo group are doing worse, to express it in the opposite way. And what we can see with the statistical test that we perform is that the probability of that happening if the drug has no effect is very, very low. Therefore, we would conclude that the drug has an effect. And one of the ways that we can measure that is by comparing how long did it take half of the dogs in the placebo group to meet the endpoint, and how long did it take half of the dogs in the pimobendan group. And that difference between those groups is actually about 15 months or more than a year. So putting them onto medication delayed by more than a year the time to heart failure for the average dog in the trial, which is quite an important conclusion to be able to draw. So before I go on, let me just have a look at what's in the chat. Yeah, okay. Notches in the line, that's such a good observation. An upward notch happens when the dog is what's called censored, and I really won't go into that now, but basically dogs can leave the trial either because they meet the endpoint or something else happens to them, like the owner moves away or they're lost, or the owner decided to remove them from the study, and that's what the little upward notches are for, but very good observation. So what effect did our study have? Well, what the effect was is that since we published it in 2016, it is now pretty much globally recommended that dogs with this condition at that stage receive pimobendan. So dogs with degenerative mitral valve disease with enlargement of their heart are getting the drug. And the gratifying thing that that means is that lots and lots of dogs now around the world are prevented from going into heart failure, or at least are taking longer to go into heart failure than they otherwise would, because of the fact that they're receiving this drug. And that's a really nice thing to be able to conclude. This is a dog that's absolutely typical poster child for mitral valve disease. And this is Nicola, who's a research nurse who helps me and is invaluable in the research that I do. So that's kind of the end of my example from the mitral valve disease in dogs. But let's get back to a couple of our earlier questions. So what about hydroxychloroquine and vitamin C? There was a study that was published actually yesterday. This is how hot the news is in this presentation, which also shows when I got around to preparing it. But there was a randomized trial of hydroxychloroquine as post-exposure prophylaxis for COVID-19. And what they did was they took patients who had had an exposure to other people with COVID-19. And as you would expect, they randomized some to receive hydroxychloroquine, they randomized others to receive placebo, and they followed those patients over time. Now, bad news for Donald, unfortunately. What they found was when you looked at the primary endpoint, which is how many people actually ended up getting COVID-19, although in the hydroxychloroquine group, it was 49 and 58 in the placebo group, that's a difference of only 9 patients. And when you look at the probability of that, it's really quite probable that that came about by random chance rather than that the drug has a genuine effect. And so they would conclude from this, or that there is insufficient evidence from this trial to suggest that the drug works, and that makes it more likely that the drug doesn't work. You can't actually conclude that the drug doesn't work until you did a study on a much larger population of patients. They had 800 patients in their study. And they showed that in another way, which is the percent of patients with COVID-19 on different days of the study. So day 5, day 10, day 14, it didn't differ significantly between groups. So again, unfortunately, it doesn't seem that hydroxychloroquine has a good effect. And the rather bad thing that they showed in the trial was participants experiencing side effects. Even in the placebo group, some people think that they're experiencing side effects even when they're not. So that's kind of a placebo effect of a side effect, if you like. But many, many more people receiving hydroxychloroquine developed clinical signs of side effects by comparison to people in the placebo group. And these are the sorts of things, so nausea, upset stomach, diarrhea, all those kinds of things. So hydroxychloroquine is ineffective, it appears, and is associated with quite a lot of rather unpleasant side effects. Similarly, I mean, if you're ever interested in knowing how effective any medication is, there's this wonderful collaboration called the Cochrane collaboration, where what they do is they publish reviews of the effectiveness of evidence from multiple clinical trials, and they combine it in what's called a systematic review. And even answering my original question about whether or not vitamin C prevents or treats the common cold, there is some data out there. What it says is that there were 7 well-conducted trials looking at the comparison of administering vitamin C in 3,300 episodes of the common cold, and there was no consistent effect of vitamin C seen on the duration or severity of colds in those therapeutic trials. So sadly, taking vitamin C when you already have a cold would appear to be almost pointless. So if we, I'm just going to look back at some of the questions that have just been popped in. So could the same or similar principles in treating dogs apply to ARVC? So ARVC is a quite different disease. So arrhythmogenic right ventricular cardiomyopathy. Certainly we have done a similar study looking at dilated cardiomyopathy, and pimobendan is similarly effective, but dilated cardiomyopathy is a somewhat less condition. Is the placebo effect more prominent in humans? There's a really good question. I was once asked by a medical doctor why we need to give placebos to dogs. And the reason is that the people who are evaluating those dogs are human. So me as a cardiologist or the owner of the dog, and they could be biased by knowing whether the dog was on treatment or not. In fact, we showed in this trial, and I had not the data that I presented here, that there was a mild placebo effect because many of the dogs in the placebo group that went on to medication appeared to improve despite the fact that they were on no medication at all. What made me want to go into research? That's a great question. I started out as a clinician, and I ended up encountering lots of questions that I couldn't find the answers to. And it made me want to go and find those questions. So I was motivated more from the point of view of wanting to know clinically relevant results of studies than because at some point early in my career, I decided I wanted to be a researcher. In fact, early in my career, I decided I didn't want to be a researcher, and I almost kind of became one by accident. Yeah, high p-values, they effectively mean no good evidence of effect. Why are the numbers in the groups uneven? Because of randomization. If you're going to randomly allocate patients into 1 or 2 groups, although it's likely they'll be approximately similar in size, they'll never be identical in size. What made us suspect that pimobendan would work? The main thing being that it worked in later stages of the diseases and reduced heart size. Should it be ethical for the placebo group to receive a later treatment? When they went into heart failure, they were allowed to go on to treatment, undoubtedly, so they could then switch. Yeah, Cochrane collaboration is mentioned probably in a good way by Ben Goldacre, I should think. Dog's lifestyle, what we wouldn't measure lifestyle, but what we hope is that as what we would call kind of a confounding variable, that it would be equally distributed between the two groups. That final question from Timothy Riley, why don't dogs get coronary artery disease? If I knew the answer to that, I'd be a very rich man. And the reason being that in contrast to humans, almost every other mammalian species does not get coronary artery disease. And so coronary artery disease is an almost uniquely human phenomenon, rather than being, rather than, I would rephrase that question, instead of why don't dogs get coronary artery disease, it would be why do humans get coronary artery disease? And that's kind of all down to the fact that we're not very good at dealing with lipids, as far as I can work out. So there we are. I will stop sharing my screen, and then you can at least briefly see me. If there are any other questions or anything that anyone's got from the chat, I would be happy to take them, but otherwise I will hand over back to RVC Access.
Yes, so well, thank you very much, Adrian. That was absolutely phenomenal. I've made so many notes. I'm just curious. I mean, it must be the most amazing feeling in the world when you've done a 5-year study and you've proved that it has, you know, a positive effect, and then eventually becomes globally recommended. How did that feel?
Well, as you say, it feels great. Actually, I can remember the sort of first moment when I saw some of the preliminary analyses from the study. And it was evident that it was having an effect, and that it was having a quite profound effect. And I thought, whoa, this is going to change everything. And it did. And that's really good. I mean, it's one of those things where I can't pretend that I did it alone. In that there were 37 other people who were attributed as authors on that paper, everyone quite rightly in terms of their participation, and then the sort of the financial support that goes with it. So it's not entirely of my own doing, but it's a very satisfying experience, because in the end, what you know is the important thing is lots of animals are going to live a longer period of time not suffering from a significant disease. Lots of owners are going to have their animal for longer than they otherwise would have done as a consequence of a medication where you've demonstrated its effectiveness. So it's really good. There's some good chat going on here.
Wow.
Why is 5% significance used? That's an absolutely arbitrary level, but everyone does it. And there's a really interesting book that anyone who was in that enjoying stats thing, there's a book that, I can't remember the title of it, that I read recently, which is about sort of approaches to statistics and goes through some of the history of it. It was basically just arbitrary to start with. And then there's some really good discussion in here about type 1 and type 2 errors. And so the different types of error are that you may accept as true a hypothesis that isn't, or you may reject a hypothesis that is true. And that's a risk basically of any form of statistical test. So the best thing is to then do confirmatory studies or follow-up studies, which is great. Good questions. Okay.
Can I ask you something about COVID-19, Adrian?
Yeah, indeed. Although I'm probably no more expert than Joe Bloggs.
Well, I think you perhaps are slightly, but obviously it's like a bit of a race to the North Pole at the moment. Who's going to be the first person to, get the vaccine?
Yeah.
If you were to have a suspicion, if all goes well, when do you think realistically we could potentially have a vaccine?
I really don't know the answer to that. I mean, everyone is talking about numbers like somewhere 6 months, 12 months, 18 months. So the problem of having an efficacious vaccine then is also making enough of it and administering enough of it to the population for there to be enough population immunity that the disease stops spreading. So I don't think it's just as straightforward as simply developing the vaccine. The other thing that sort of I ponder on slightly, and please don't for one moment believe that I'm an anti-vaxxer, but the long-term safety of the vaccine is something that almost by definition can't be known. because it will be a new thing that will only just be being administered to a large population of individuals. And what will happen is, at the outset, everyone will be very, very keen to receive it because the disease you're trying to prevent is very prevalent. But as the disease diminishes in prevalence, because lots of people are vaccinated, then is there a point at which it sort of crosses over and stops being worthwhile being vaccinated? But I, like everyone else, want there to be an effective, safe vaccine as soon as possible so we can go back to a more normal way of life.
Fantastic. Okay, well, I think we might have, okay, one question here. Are clinical trials usually carried out before and transferring medications between species, like between dogs?
Yeah.
Or is it based more on?
I think, yeah, that's a very good question. And it depends in part on the type of disease that different species suffer from. So cats do suffer from heart disease. They suffer from heart disease quite a lot. But the type of heart disease that they get is very different to what dogs get. And so the cats get a condition called hypertrophic cardiomyopathy. And in hypertrophic cardiomyopathy, the observed benefits of pimobendan may be it would be less logical to assume that pimobendan would be effective in that disease state. What I'm really interested to know, and in fact, I've made some effort to make contact with people from the human field, is that elderly human patients get a similar degenerative mitral condition to what dogs do, for which there is currently no recognized medical treatment. In fact, most human patients, despite their age, if they have severe valvular disease, end up having surgery. But there's a small population of humans who can't have surgery for one reason or another, and yet suffer from significant mitral valve disease. And I wonder whether we might, for once, be able to sort of flip a medicine back from the veterinary field to the human field, and having established its effectiveness in a veterinary indication, to then have it begin to be given to treatment to humans. That would be a really fascinating thing to see whether that happened.
Okay, so this question's come up a couple of times. What are the complications of conducting
clinical trials like exotic animals?
Exotics.
The main limitation actually with exotics is that because there aren't very many of them, so they're a much rarer pet, it would be difficult to conduct a study in a large number of them. And often clinical trials need to have quite a lot of individuals recruited to them. The trial I was talking about had 360 dogs in it. And if you're treating something quite rare, or if you're treating quite a rare condition, it's unlikely that you'll be able to get good evidence. And so what you'll find is that the vets who treat exotic animals, or the vets who work in zoos, for instance, are fantastic at the application of comparative evidence. And so they'll say, well, I don't know that whether or not this works in this antelope, but I know that it works in a camel, or I know that it works in a sheep. And applying what I know about those two different species, I'll think, well, it will probably work in the antelope, so I'll give it some drugs. And so they get very good at the approach that others have talked about, which is the application of evidence from one species into another species. I've also been involved sort of as a sideline, very fascinatingly, in some studies where people have looked at heart disease in chimpanzees, for instance, and looking at it from the point of view of its similarity to heart disease in humans. So what you have is quite a very rare species in which you couldn't study the sort of population nature of the disease very effectively, but then you can compare it to humans. Question about what made us suspect pimobendan. We'd already shown that pimobendan was effective in a later stage of the disease. And what we knew from a study we'd done before was that it actually seemed to make heart size reduce slightly. And so part of the rationale was, well, if the heart gets smaller, can we, by doing that, take the dog back sort of earlier in its disease course and make it progress more slowly? So that was part of the rationale for it. And other drugs had been tried and been shown to be ineffective. So that was another reason.
Lovely. Okay, so we're going to have to wrap up there, Adrian, but that was fantastic. That we could sit and talk to you for absolutely Do you have any sort of parting words for the group? Obviously, these are all guys that are looking to, you know, go to vet school and become vet. They go into research. Do you have any sort of parting words for them?
If I kind of reflect on my own career, first of all, everyone tells you it's really difficult to get into vet school, and although that may be the case, whatever you do, don't let that put you off trying, because the one way to make sure you won't get into vet school is to not apply. Then the next thing is that a lot of people, you know, if I sit now at my career and look back, people could imagine that was like a logical series of steps that I took and choices that I made. But actually what I tended to do in my career was pursue the things that were interesting to me and that I was enjoying at that point in time. And the other thing, which is an unusual bit of career advice to offer people, when you think about it, it makes sense, is that if you find something easy, it's quite possibly because you're good at it. And as it turns out, there were bits of veterinary medicine that I found easier. I also find numbers quite easy. So from the point of view of statistics and statistical analysis. And so I would say, pursue a bit of your career that you enjoy, pursue a bit of your career that you find interesting, and don't have too determinate an idea of what you're definitely going to do later on. Kind of go with the flow and see what happens. And good luck.
Well, thank you very much. So for all of the latecomers, fear not. This is being recorded and it will be uploaded to the website later on. Professor Boswood, thank you so much once again. And students, we look forward to seeing you in the next presentation by Dr. Zoe Mitten.
Thank you. My pleasure. Bye.